the webinar is automatically muted to keep the noise down. And questions can be asked during the webinar, but they'll have to be typed in on your screen. In order to send a question, go to the question panel of the control pane, which should be on the right-hand side of your screen, and enter the question in the provided field, and then click send. And the message will appear in our webinar administrator's screen. We won't see those right away, but he'll get them and in another room and print them out and bring them to us. And then we'll address the questions at the end of the webinar. But we're only addressing questions relating to today's topic. Any other questions can be directed to the operator support hotline at 866-503-3926 or to the regional office. And we'll have that number again at the end of the presentation on the screen. Also, if you're trying to get our attention by, I think there's a raise your hand function. We won't see that because we just have the PowerPoint up on our screen in this room. So the best thing to do is if you need something, go ahead and ask the question, and the webinar administrator will bring that into us. And we have one handout available for today's webinar, which is the PowerPoint presentation that we're using today. And it's available in the options menu. If you open the options menu and then click on the plus sign next to the word handouts, a box containing the handout will appear and you can access it there. So now I'm going to introduce today's speakers. My name is Michele Strauser. I'm the Bureau of Human Services Licensing Training Director. With me is also Dahl, Krow, who's the hotline manager, and Cody, who is the regional director for the central region of the Bureau of Human Services Licensing.
Can I just remind them that you will not receive a certificate for this webinar. Your login will be stored electronically, and all you need to do is to basically log your participation today in your training log as you would any other kind of training that you go to, and that will suffice as far as proof that you attended today.
Okay, thanks, Dahl. And our outline for today is we're going to go over the definition of direct care staff person for assisted living facilities, talk about initial training required for direct care staff and ancillary staff, and the annual training required for all the staff in the home. So now I'm going to have Cody take over, and he'll start with talking about the definitions of the different types of staff people in assisted living homes.
Okay, and before I really get into the definitions, I want to ask my compatriots to slow me down a little bit if I start to talk too fast, because I have a tendency to do that. So, and I do want to talk about one other thing too before we get into these definitions, which is just a helpful tip that I have come to know well from the inspectors that have come back from inspections regarding an inspection-ready book. So a lot of the requirements that we're going to talk about today can be surprisingly complex. It seems like it should be a simple requirement regarding the annual and initial training, but there's a lot of documentation that homes have to keep stored and organized. So, you know, unlike a resident record, which is required to be stored confidentially and individually, there's no such requirement for staff records. So I would strongly recommend that administrators at least have some kind of storage system where they can easily access, say, all initial competency tests, the training logs, a training-specific binder that lists all of your current staff, that has a current staff list attached to it. And these kinds of things can just prevent a lot of headaches for you and a lot of headaches for the inspectors. It makes it very easy to measure the many regulations we're going to talk about today in a pretty short period of time. So I hope that will be a helpful tip for you going forward. So with that, we'll get into some definitions of staff, of the various staff people that are employed by an assisted living residence. First is an ancillary staff person. That's an individual who provides services for residents other than direct assistance with activities of daily living. That can involve staff who just conduct assessments or care planning or care management activities. It can include RNs, LPNs, or other professionals who meet the requirements of their professional license, but also activity planners, housekeepers, cooking staff, or other facility staff. And we'll get into transportation a little bit later, but somebody who might serve only as a driver could also qualify as an ancillary staff person, depending on their duties. So that brings us to the direct care staff person, which is a staff person who directly assists residents with activities of daily living and instrumental activities of daily living, and provides services or is otherwise responsible for the health, safety, and well-being of the residents. Excuse me just a moment. So the initial orientation, 65A requires that prior to or during the first workday, all staff, including ancillary staff and substitute and volunteer staff, have the following orientation. This is something that's very, very important, obviously, because it's a fire safety issue, but it also needs to be specific to the home. And inspectors are going to review the training documentation and staff records to ensure staff were trained in all areas of the regulation prior to or during that first day of employment. We may also interview staff to determine if the training was provided. The various sections here are evacuation procedures, staff duties and responsibilities during fire drills, as well as during emergency evacuation, transportation, and at an emergency location if applicable. Number 2 is very, very important because we have seen that many times over the years where temporarily staff have been served at, or residents have been served at, say, a firehouse or a local hotel. There might be a local emergency in the area where residents need to be temporarily relocated. It's very important that you have contingency plans to make sure that staff are available to provide all the same services they would get in the assisted living residence in the event that they're temporarily relocated. Number 3 is the designated meeting place outside the building or within the fire safe area in the event of an actual fire. That designated meeting place and fire safe area should be designated, preferably in writing, by a fire safety expert. That's important to make sure that, if it's an exterior location, that it's far enough away from the building that, residents would be safe from falling debris in the event of an actual emergency or something like that. Number 4 is smoking safety procedures. We've seen a lot of facilities go smoke-free, which obviously we'd always recommend, but in the event that smoking is permitted, then there should be policies in place to ensure that there's safe procedures. Number 5, the location and use of fire extinguishers. Number 6, smoke detectors and fire alarms. And number 7, telephone use and notification of emergency services. Okay, and we'll move on to CPR first aid. So there's actually a couple of different regulations that deal with the CPR first aid requirements in a personal care home. 63A requires that there be a ratio of 1 to 35 one staff person per 35 residents who are trained in first aid and certified in obstructed airway techniques and CPR. 65C and D specifically relate to ensuring that staff have those trainings before they're counted in the 1 to 35 ratio. It doesn't necessarily mean that all direct care staff are required to have CPR first aid, but the 1 to 35 ratio needs to be met in the home at all times. And it's also worth noting that the RCG defines obstructed airway techniques as responding to choking, which unfortunately is something that we see relatively frequently too. So that's the importance here.
Neil, would it be a requirement that you have one person at least on every shift that has CPR training?
Well, the way that 63A is worded, it accounts for having one staff person for every 35 residents. So let's say a home has only 40 residents. It might be appropriate for only one staff person to be there at night based on care needs. But related to the first aid training, obviously at that point they'd have to have two because they've got more than 35 residents. So that's the reason for these three regulations that are closely intertwined but in different sections. It also accounts, 63A also accounts for having perhaps their ancillary staff that are trained in first aid CPR. They can count towards the ratio, but obviously they can't count towards direct care services because that's not something that they provide.
What about this guy up on the screen here?
Oh, I just chose the creepiest CPR doll that I could find. I apologize if I've startled anyone.
Well, I think that's Resuscita Andy, isn't it?
It might be. I don't know.
Okay. All right.
Okay, we'll move on to 65E. And again, I know I'm moving through some of these topics kind of quickly, but if you've got questions, feel free to enter those onto your screen, and we'll come back around to anything that needs a little bit more clarification. Excuse me just a moment. So 65E is related to the training that's required within the first 40 scheduled working hours. Now, this applies to direct care staff, ancillary staff, substitute personnel, and volunteers. So pretty much everybody working in the home. This would involve people who are drivers, people who are activities staff, people who are receptionists, anyone who's working with direct contact with residents.
Neil, what do they mean by substitute personnel?
Substitute personnel would be anyone who steps in to fill in for a direct care staff. Obviously, they would still be required to have all of the trainings that we're going through today if they're providing direct care services. Would
that be like contract staff that you get from an agency?
No, not contract staff.
Okay.
You're trying to throw me for a loop, aren't you?
No. I wasn't sure if that covered your people from, say, the home hires some contract staff from an agency to do direct care in the home.
Well, if it's contract staff doing direct care and they're hired by the home, then there's no difference between them and a direct care staff. That would still be a direct care staff person that would be required to have all the trainings we're talking about today for direct care staff. And these are very important ones. I mean, even if it's an outside agency coming in, I would still recommend some of these trainings as they relate to your facility. Some of them are a little universal, but some of them can certainly have things that are specific to the home that you're in. So these topics involve resident rights, the emergency medical plan, mandatory reporting of abuse and neglect under OPSA, reporting of reportable incidents and conditions. Certainly, I would recommend that for anyone that's in the home, strictly from the standpoint of the administrator or other responsible staff need to be aware if there are incidents that are happening outside of view of other staff at the home. Safe management techniques and core competency training that includes person-centered care, communication, problem-solving and relationship skills, and nutritional support according to resident preference. Again, we don't designate what the source needs to be for these trainings. They can be provided by the administrator or another designated staff person in the home. You don't have to make fancy certificates, but who doesn't like a certificate? We can all thank Dahl for not getting one today, but but keeping a detailed log of what staff receive these trainings in the first scheduled working hours. A lot of what the reps see are checklists that include a list of all the topics to make sure that every topic is covered. Not every topic is going to be as in-depth as every other topic. The goal here is to make sure that all of these issues are hit during that first 40 hours, and that you're keeping documentation that each staff person has them. I think we'll move on to 65F. So 65F is that ancillary staff shall have a general orientation to their specific job functions as it relates to their position prior to working in that capacity. This requirement's for any ancillary staff who do not do direct care services to ensure they're taught how to do their job, obviously. So that could be a maintenance man. Again, it could be somebody who does transportation. It could be an activities person who doesn't provide direct care as well. People in those sorts of roles. I'm sure we'll have some questions about that at the end. So 65G, the initial training and test. Direct care staff persons may not provide unsupervised ADL services until completion of 18 hours of training in the following areas. Training that includes a demonstration of job duties, followed by supervised practice, successful completion and passing of the department-approved direct care training course and passing of the competency test, and initial direct care staff person training to include the following: safe management techniques, ADLs and IADLs, personal hygiene, care of residents with dementia. You know what, there's actually a second slide to this as well, and I'm not going to read all of them, but there are a lot of topics here that, again, I would suggest the same as with the last slide, that you keep a checklist of the topics that staff are being trained in, and that you can demonstrate that they received all those topics. Are there any topics, Michele or Dahl, that you think I should go into a little bit more detail? Again, I recommend anybody on the call to also ask any questions if they want clarification on any of those.
I think it's important to mention here that these are three separate requirements under 65G. The online training under 65G2 does not cover the required trainings in 65G3. I just want to make that clear, because many of the things under 3 are things that can't be and aren't covered in the online training. There's meant to be 3 separate regulations for a reason. You know, the online training is sort of an introduction that covers most things a direct care staff person would need to be introduced to or understand before they start working in a personal care home or assisted living home. But under 3, it's more detailed training, and many of those things are impossible to cover in an online training.
Yeah, I think the spirit of the requirement here is that the 65G1 involves sort of a buddy system or job shadowing during their initial employment. 2 is the department required competency test and course that's accessed online. And then 3 is going to be more specific towards the home itself and to the residents that you each individually serve, and provided by the administrator or a designated person who trains staff at the home. We'll move on to exemptions. So the RCG does have a couple of good, and if there's anybody who's not familiar, the RCG is the Regulatory Compliance Guide for 2800, and it essentially lays out each regulation. It has a discussion that explains the importance of it and the primary benefit, and then also inspection procedures, which explains how inspectors are going to look at it when they're on site. So the RCG does have a lot of good graphs that explain the different training requirements and shows which types of staff need which types of training. But there are some exemptions for that, and any staff person hired on or before April 24th, 2006, who has not had more than a 1-year break in service is considered quote-unquote grandfathered regarding 65G. Any volunteer trained on or before that date who's not had more than a 1-year break in service. Certified nursing assistant, CNA with a current certificate in good standing, an LPN, an RN, a physician with a current license in good standing, an emergency medical technician, again with a current license, and any staff hired between April 24th, 2006 and October 31st, 2007 do not need to successfully complete the department-approved direct care staff training course or pass the online competency test. I think that's all I have to say about that.
I think that covers it.
Okay. Annual training. Most of what we talked about so far regarding the initial 40-hour training, the initial competency test and things like that are sort of once and done. If you hit your mark on the timeliness and you make sure that you get all the topics, you're going to be in compliance in perpetuity for those. But the annual training could be a little bit trickier. There's several requirements here and many different types of topics that you can train on. One thing I want to start off right off the bat with is remember that there is no department-approved annual training sources for staff. That is not true of administrators. Administrators can find the training directory online, which has actual approved sources for training content. But for direct care staff and for other types of staff, the home can select all kinds of different sources, anything from local hospital, the local area agency on aging, various different local organizations that can offer a lot of the topics that we're going to talk about. So, that might be a question for Michele. Relias, I've heard of it. I believe it is acceptable.
Right. A question came in as to whether Relias is acceptable, and yes, a lot of homes use Relias for the direct care staff training, as well as the administrator training. But the difference is for direct care staff, the home can pick any training in there, and it doesn't need to be approved by the department. But for administrators, they need to make sure the training that they choose from Relias is already approved by the department.
But I'd also recommend that if you come across a particularly good training source, and I think Relias is used pretty frequently, certainly pass that along either to the next inspector you see, or give a call and talk with your regional director or regional licensing administrator. I mean, part of our goal and part of our job is to also provide technical assistance and best practices. And if you find something that works particularly well for your community, there's a good chance that it'll work well for other communities. So we want to know about it. We'd be happy to pass that along as well. So for 65H, direct care staff shall have at least 16 hours of annual training related to their job duties. For those of you who are familiar with personal care home regulations, that's a few more hours than the 12 that's required there. So that's important to remember in assisted living. The residents is encouraged to provide training on a variety of topics to enhance the direct care knowledge and skills. The training must include all of the topics required by 65F and G, but can include other topics as well. In addition to training provided by the home, the following types of training also apply. So training hours approved for continuing education requirements for nursing home administrators, registered nurses, and licensed practical nurses. Documentation that the course has been approved as a training source by the Department of State must be kept. Any course from an accredited college or university is acceptable. Up to 6 hours of medication administration training, medication train the trainer course, or medication train the trainer recertification required by 190A. That's acceptable as well. And there's a few more here. Next slide. Training hours spent in the diabetes education required by 190B. And up to 4 hours of CPR, obstructed airway, and first aid training required by 63A. Orientation hours required by 65A, B, and D also count for that first year. The residents may select the direct care staff training year for calculation of the 16-hour training requirement, which may differ from the administrator training year, C64C. The year may be the calendar year, the home's fiscal year, the direct care staff's anniversary date, or another 12-month period as determined by the home. The home must be able to verify the training year used. So this is another thing that comes up quite a bit. I would strongly recommend that regardless of what system you use to determine your training year, that you just keep it the same for everyone. I think you're making a lot more work for yourself than you need to if you go by hire date and then have to track all of your staff individually to ensure that they're getting their 16 hours of annual training. I would recommend making it a calendar year. Obviously, there are some things that are going to relate to grace periods, and there are some other circumstances I can think of where we would certainly be up for discussion regarding the time frame if any kind of issue came up with getting timely training. So, like I said, I think the important thing is keeping everybody on the same timeline, just to make it a heck of a lot easier for everybody.
How does that work, though? When you mentioned that, if a person, if the home is on a calendar year and the person is hired, let's say in October or November, do they have to have their 16 hours by the end of the?
And that's the kind of issue I'm talking about, where I think we'd be up for discussion. I mean, if somebody's hired at the very end of the year and there's only a couple of weeks, obviously 16 hours is going to be hard to get in. So at that point, we'd be looking at it on a case-by-case basis. But certainly you'd want to have a plan in place immediately to get as much training as you can before the end of the year, and then looking forward into the first full year of their employment. And actually, during our renewal inspections, we're going to be looking at the first full training year for the staff person anyways, and we're only going to be going back the previous year to the previous full training year for each staff person that we pull as part of our sample.
For the annual training.
For annual training.
For new staff, we'll be looking for their new staff.
Right.
Training.
And in that case, it's a little bit more hardline. Obviously, you don't want to have staff providing unsupervised direct care services prior to having a lot of the trainings that we already talked about today. So that there's going to be less wiggle room. But when it comes to the annual training, the important thing is demonstrating that you have a good plan in place to track and ensure that the annual staff training's done, that you have a good record of other staff receiving it. And again, if it comes down to the end of the year and it's a couple of weeks, then we'd be up for discussing that individual circumstance. Just one other thing I wanted to mention about
Go back, okay.
Is the home must be able to verify the training year used. That can be just as simple as a history of the training year and the staffing documentation. I mean, we're not going to, or the training documentation. We're not going to ask you to sign an affidavit or anything like that, but we're not totally unreasonable. But just demonstrating what your training year is through your documentation is sufficient to quote unquote verify it. Okay, we're going to talk about some annual training topics next. So training topics for the annual direct care staff persons shall include the following. It's important to note that these are required topics annually, each one of them. So there are going to be some things as we go through here that some topics that are not listed here that you may want to train in, and that would be good. But these are the things that are required annually. Medication self-administration training, instruction on meeting the needs of the residents as described in the pre-admission screening form, assessment tool, medical evaluation and support plan, care for residents with dementia and cognitive impairments, infection control and general principles of cleanliness, universal precautions in other words, personal care service needs of the resident, safe management techniques, care for residents with mental illness or intellectual disabilities or both if the population is served in the residence. And one thing I do want to mention about that, one question that comes up frequently is, well, we don't serve any residents that have dementia or cognitive impairments, or we don't serve any residents that have mental illness or intellectual disabilities. And the answer I typically give administrators is, well, you don't right now, but you might. That doesn't mean that the training in those areas needs to be particularly in-depth or complex. If you don't serve anyone with those needs, I would expect that if that changed throughout the year, that additional training would be secured to ensure that staff are properly equipped to provide services to residents who have those needs. But they are, all 7 of those topics are required. So regardless of what your population is at the time of an inspection, that's what the inspectors are going to be looking at.
So we do have there in red on number 7.
Oh, I'm sorry. If the population. Okay,
right.
well.
For number 7.
For number 7,
right.
not for number. You should stop me earlier.
Sorry.
I just went through a whole.
All of them are required except number 7. That's only required if the population is served in the residence.
Okay, sorry about that.
I believe that's the way the regulation reads. I copied and pasted it.
It is, but most of what I said still applies because, again, I wouldn't expect that the training in that area would be very complex or robust if you don't serve that population. However, if that situation changes throughout the year, then I would recommend that you have more in-depth training, again, to ensure that staff are well equipped to meet those residents' needs.
Yeah, I would say that certainly is a best practice, because a lot of places you may not be aware that a person has a mental illness coming in. Depending on where the admissions information came from and how accurate it is, but oftentimes you find that they in fact do have some sort of a mental illness or emotional condition once the person is there.
That certainly does happen more often than we'd like. I mean, I've seen homes do excellent pre-admission screenings and still discover new needs as time goes on. I mean, I guess that's just life. So.
Right, and we all know that many older adults have depression or anxiety.
And conditions can arise as time goes on. All the more reason that these 7 topics are very important, particularly when these populations are served in the home. Should I say anything about safe management techniques? I feel like that's always kind of a buzzword that doesn't get a lot of attention, but safe management techniques is basically positive interventions and things like that. You want to train staff on things like an absolute prohibition on restraint. You want to train staff on redirection and using, again, positive interventions to meet resident needs. Again, particularly if you're dealing with residents who may have a mental illness or an intellectual disability, you can see those kinds of issues come up.
I think validation training is very critical in terms of working with people that have dementias.
In fact, all of the licensing reps have received some training in validation as well. I mean, it's not something that we're typically going to put into practice while we're measuring compliance with regulation, but seeing that kind of person-centered, compassionate care put into practice, that's the kind of thing that would definitely fit well under safe management techniques. It's a whole body philosophy, mental, physical, ensuring the health, safety, and well-being. A couple more annual training topics. Under 65J, direct care staff persons, ancillary staff persons, and substitute personnel and regularly scheduled volunteers need to be trained annually in the following areas. These are also required, as you'll see. Fire safety completed by a fire safety expert or by a staff person trained by a fire safety expert. There's a whole list in the regulations of who qualifies as a fire safety expert, but it can be the local fire chief or someone the fire chief designates. And if the fire chief or the fire chief's designee trains one of your staff people, they can be the designated trainer going forward. Number 2 is emergency preparedness procedures and recognition and response to crises and emergency situations. We touched on that earlier. Number 3 is resident rights, and it's resident rights as defined by 2842A through Y. 5 is falls and accident prevention. Again, even if that's not a typical event in your home, circumstances can change throughout the year, so that's important. And also, I would say the number 1, maybe number 2 incident report that we get statewide would be falls. So it's definitely a frequent thing in personal care and assisted living. And new population groups that are being served at the home that were not previously served, if applicable. That's pretty self-explanatory.
What would be an example of a new population group?
Also, just as an FYI, the definition for a fire safety expert, which comes up with some regularity, is in the beginning of your blue book on page 8. Everything is alphabetized there in terms of definitions, but the fire safety expert is defined as far as who qualifies for that.
Okay, and I had asked, like, what would be an example of a new population group that was served in the home that may not have been served before? So maybe people with mental illness, if the home is going to start serving more residents.
And that is already required under the.
Yeah.
That's true. Yeah.
And frequently, we're getting more and more discussion about persons with brain injuries for various reasons that come to the home.
That is certainly one too. Yeah. So we're going to move on to the record of training. I spoke a little bit at the beginning about the importance of putting together something called an inspection ready book. The record of training, 65L lists various subjects that need to be on your record of training. You don't need to use our model form, but it's available as a guide. You can certainly make your own form, provided that it has all of the same content that's required by 65L. It's the staff person trained, the date, source, content, length of each course, and copies of any certificates received.
And this model form is actually the one for 2600. We don't have the ones created for assisted living, but that is actually in progress right now. If it's helpful to you, those should be on our website at some point, where we have the model forms for assisted living as well as personal care homes. But this one can be used. I mean, you would just change it to 2800 there.
And you can even use this for that initial training that has the 20-some different topics. You can list the topics down the side, or I mean, you have to modify the form a little bit, but it might even be easier to modify the form in such a way where you list the topics down the side and then have various blocks for various staff persons' names. But again, like Michele said, we've got a model form coming in the near future, so. And then we've got the staff training plan. And this is an issue that we see relatively frequently, we might find that a lot of the training is in place, but the way that the training is organized is not in the staff training plan to ensure that it's received every year. So it does need to be developed annually. It must include training aimed at improving the skills and knowledge of the residents' direct care staff persons, and it must include, at a minimum, the name, position, and duties of each staff person, the required training courses for each staff person, the dates, times, and locations of the scheduled training for the upcoming year. And documentation of compliance with the staff training plan shall be kept as well. So essentially just filling out the plan that it was followed is sufficient to meet that. There was something I wanted to say about this. I don't remember. It'll come to me in a little bit, I'm sure. And then 2800.69, in addition to the 16 hours of annual training, each direct care staff person working in a secure dementia unit shall have an additional 4 hours of annual training related to dementia care and services within 30 days of hire and 2 hours annually thereafter. So that's a slightly different requirement from 2600 as well. And it's something that, I think most of the currently licensed assisted living homes have gotten a handle on it, but it was certainly, at first, it was a change, and it was just something that was easily missed. So that's important to be aware of.
Right, and it can be any related to dementia care and services, so anything relating to that in it that's going to help the staff care for the residents.
And a big thing to remember for a lot of these training topics that we've discussed, if it doesn't specifically say that there's a required source or something, these can be provided by the administrator. They can be provided by someone designated by the administrator. There's very few things that are required to be provided by a certain source, like the fire safety expert training. But the important thing is just making some kind of file for yourself to ensure that you're tracking each staff person, that you're holding them within a training year, that you have a plan for the upcoming year, and that you're ticking off those topics as they're getting the training throughout the year.
Right, and I don't know if this is what you were thinking about mentioning that you forgot, but there is a model staff training plan. That's not, we were looking at the record, the model training record here, but there's also a model staff training plan available on our website. You don't have to use that form, but you can use it as an example, and that is another one that's in process of being converted to 2800 for assisted living. That'll be available on our website as well.
And I remembered what I wanted to say, which is that also remember that the staff training plan can change. I know that 66C requires that you need to keep documentation of compliance with it. That's not, I mean, that's kind of a harsh word for what we mean. Certainly, life gets in the way. Sometimes there's other things that are more important, and there might be changes to the dates or to the content even, and that's okay. Just like with the assessment and support plan that we call a living document, this can also be a living document. It can change as needs arise that require that.
What if they identify a training need that's lacking and they want to switch one out? You know, say they're planning to do a training on something and then they decide something else is more important and they switch it out on the training plan. Is that okay?
That's fine. My recommendation is just to document, attach a note to the training plan explaining what kinds of changes you make throughout the year. I would initial them and date them, and I would keep documentation of what you did, but that's perfectly fine. Encouraged even, because that shows a level of engagement with the training plan to make sure that you're, you know, rolling with the punches and making sure that the topics that are most appropriate for your facility are the ones that are being sought.
So it's not completely carved in stone when it's created.
Exactly. I would much rather see a training plan that has those kinds of changes made to it than just one that hits the base topics. That's a good level of engagement.
Before we get to questions, were you going to mention something about transportation, or did you already cover that?
Oh, that's right. Just one of the questions that come up a couple of times recently is regarding staff that transport residents. And it wasn't listed in the PowerPoint that we have here, but 171B4 requires that a staff person who that at least one staff person who accompanies a resident during transportation must have the orientation described in 65. And that's 65B, which is the direct care competency test that we talked about earlier. I can talk to anybody who has a more specific circumstance if they want to discuss regarding this, but in general, the important thing here is that if the person who is the quote-unquote driver is an ancillary staff person, that it's important that they not be providing any direct care. If there's any direct care needs that a resident has during transportation, then there really should be an additional staff person going along with them, or the driver should have the full gamut of direct care staff training. And that includes even something like supervision. Obviously, that could potentially be a dangerous situation in a vehicle if a resident needs supervision and there's no additional staff to assist. So that's just one extra thing that, again, has come up a couple of times recently. Just to reiterate, 171B4 requires that at least one of the staff people in a vehicle transporting a resident need to have the direct care competency test, unless the resident has more complex direct care needs, in which case there should be a fully fledged and trained direct care staff person accompanying the resident. That's pretty much all I got.
All right, are we ready to move on to the questions then? And we do have a few questions already, and I'm sure some more will roll in. But I'm going to go through and start reading them. And some of these Neil's going to answer. Let's see.
Hopefully.
All right. You showed a requirement of the RCG to have 1:35 ratio for CPR, but the RCG on the website shows 1:50. On page 53 under 63A, please advise about the difference. Now, I'm wondering,
Are you sure you're not looking at the personal care home regulatory compliance guide? Because in personal care homes, the ratio is 1 to 50, but in assisted living, it's 1 to 35.
so we should probably look at, if we don't hear back, we should look at it and just make sure it's correct.
We should color code them or something too, because the RCGs look almost identical.
Yeah.
Yeah, because it's
I was sort of getting.
clearly 35 here.
Yeah.
In the regs, yeah, but he's saying the RCG.
I guess it's also possible there's a typo in the RCG.
Right.
It hasn't been updated in several years. That's something that we'll have to make a note for the next update.
Okay. The next question, can the home care training program needed for Department of Health satisfy the direct care staff training rather than doing the online training? And that's a no. I don't know, I'm not familiar with that home care training program, but from what I understand, they use the direct care staff training program from our website for their staff.
Oh.
So, but
So if it's the same thing, then the answer is yes. If it's not the same thing, then the answer is no.
right, but only the direct care staff training program that's on our website will count.
And remember too that that's only required one time. I mean, technically, when a staff person leaves a home and goes to another home, they're still technically qualified if they haven't had a 1-year break in service. However, they're going to need their certificate, and I don't think a lot of staff take that with them when they go from one home to another. And I don't know if we're able to get that certificate, are we?
We can get them.
Oh, in some circumstances, we can get them. So staff have called about that before.
You know, is that something they have to have within a certain amount of time, or if they've had it once, that it's good for, let me look here.
My understanding is that as long as there's not a 1-year break in service, they only need it once.
Okay. All right, and somebody is asking for the contact information for Relias. They have Reliance, but it's Relias. And
That's R-E-L-I-A-S?
Right. I don't have that with me, but we can give you a call. And it is also in our training resource directory for administrators. Their phone number's in there. But we will get a hold of you directly. And if anybody else needs that, go ahead and let us know. And just give us a call. Give you a call on the hotline. And here's the number on your screen. Okay. The department approved direct care training for 2,800. Is this needed if the aides are certified nursing aides? And I think you talked about that, Neil.
I'm sorry, say that one more time.
Is the direct care training, department approved direct care training for 2,800? I guess that's the direct care staff online training.
Competency test.
Is this needed if the aides are CNAs? If they're on the nurse aid registry?
No.
I believe that's one of them that was listed here under the exemption. Yeah, I'm going to go back to that screen. All right. These are the staff who are exempt from 65G, which is the direct care staff initial training. And one of them there is CNAs, you know, people who are have active status on the Pennsylvania Nurse Aid Registry do not have to take the training under 65G, which is the initial training and competency test and all of the training under 65G 1, 2, and 3.
And can you go back to slide 17 too?
Sure.
I won't name this person by name, but I owe her a big thanks because she pointed out an error on here that I should have caught. And so I'm getting 2,800 and 2,600 confused as well. That special care training, it's 8 hours within the first 30 days, and then 8 hours annually per 2,800.236. So.
Okay, you want to read that, Rag?
Yeah, 236. Which is part of the special care unit regulations, requires that each direct care staff person working in a special care unit for residents with Alzheimer's disease or dementia shall have 8 hours of initial training within the first 30 days of the date of hire, and a minimum of 8 hours of annual training related to dementia care and services, in addition to the 16 hours of annual training specified in 65. So I apologize for that. We'll make sure that we update the PowerPoint as well. But I guess those are two separate requirements that I should have put both of them on there. 69 is accurate, but that relates to an assisted living residence, not to a special care unit. So for direct care staff that work in a special care unit, it's the additional 8 hours initially, 8 hours annually, and the annual hours are on top of the 16 hours. For all staff, they're required to have at least 4 hours, and then the 2 hours annually thereafter. And they stack. You don't have to, it's not like they then have to get, if they're in a special care unit as part of an assisted living, it doesn't mean that they then have to get 12 hours. If it's a special care unit, it's 8 hours and then 8 hours annually. If it's just the base assisted living residence, then it's the 4 hours and 2 hours annual. So thank you for pointing that out so I could clarify it. I told you, this is the kind of thing that's an hour to learn and a lifetime to master. It's surprisingly complex for.
Okay, we got another question asking the same thing. So I think we just cleared that up. For secure unit, you have to have 8 hours. Okay. Yeah. And then another question is, can we print out the slides? And yes, if you go to the, let's see, under the options menu on your screen, and then click on the plus sign next to the word handout, and you should be able to access the PowerPoint there and print it out. But if you have a problem doing that, we can send it to you if you just contact us and call the operator support hotline or email the operator support hotline, excuse me, at the address on your screen. And do we have any others? Those are already answered?
Yeah, those I'm going to take back and do.
Okay. So
there's no certificate, but this counts for 7 hours of annual training, Dale, is that correct? I'm just kidding.
I believe it's the amount of time. I had a flu shot yesterday, and now I have no voice. I don't know how that relates, but yeah, the amount of time we're going to give them 1.5 hours.
Well, I don't know.
Hopefully.
If that's what it was scheduled for, I think that's fair.
Yeah.
I tend to talk a little too fast, so.
I want to give it more time, though, because there's probably more questions rolling in.
Yeah.
It just takes a few minutes for our webinar administrator to bring them into us.
Technology here at the government is there's a hamster on a wheel down in the basement, and
And I don't know if Dale mentioned that this training counts for personal care home administrators and assisted living administrators. We're not going to say that personal care home administrators can't learn a little bit about assisted living and not get credit for it. But
yeah, I've had that question asked right after the first part 1 of the training that was on the 2600s, and yes, you can attend both and get credit for both.
we do get a lot of questions in the field and just in our daily work regarding various types of staff and what different staff count as and what training they need in their various roles. So if anybody has anything specific like that they want to discuss, I think we could do that. I talked a little bit about people who do transportation, but there's also people who come in and cut hair, which is technically a direct care service. People who run the bingo game or...
Okay, here's some more questions. Thank you. Okay, what would be considered special care? Chapter or Regulations 236 states dementia.
Special care unit is a designation within an assisted living residence that is very similar to the way that a secure dementia unit is part of a personal care home. And typically, a special care unit in an assisted living residence will serve residents who have a diagnosis of dementia due to Alzheimer's disease, although there's many different terms that can be used for various types of dementia, but also they can be a type of facility that serves residents who have a traumatic brain injury. We've seen that as well. They're not very common, but am I missing the point of the question?
No, there is a special care designation definition in the regulation.
No.
That helps.
I can read it, but I think everybody's tired of me just reading things at them today. A special care designation is a licensed assisted living residence or a distinct part of the residence which is specifically designated by the department as capable of providing cognitive support services to residents with severe cognitive impairments, including dementia or Alzheimer's disease, in the least restrictive manner to ensure the safety of the resident and others in the residence while maintaining the resident's ability to age in place. That's a mouthful.
Yeah.
And then there's sort of a subset of special care units, which is, or a service provided by special care units, which is INRBI, which is an intense neurobehavioral rehabilitation after brain injury. Again, serving residents, providing services for residents who have a traumatic brain injury.
Okay. And the next question I have is how do I get a copy of the 2800 regulations and when do we follow them instead of 2600? And if you would like a copy of the 2800 regulations, they are on our website, but if you would like a booklet, you could get a hold of Dahl, the hotline number, and he can send you one.
Please take a booklet. I've got like 600 boxes of them in my office.
And you follow the 2800 regulations when your home is licensed as an assisted living home residence as opposed to a personal care home residence.
And without going into too much detail, if you're interested in opening an assisted living residence or converting a personal care home to an assisted living residence, we'd be more than happy to discuss that more in detail individually. So please give us a call, and you can talk to me, you can talk to Dahl or Michele, or Jill Ketchmar, who many of you are probably familiar with.
Right, and taking a look at the regulations would help you determine if your home would meet the requirements or potentially meet the requirements for assisted living. Because there are some different, a few different things about the square footage requirements and physical site requirements for assisted living.
That's a training all on its own, so we'll leave any more detail for another day. But again, we'd be happy to discuss it individually. Right,
and it's not just the physical site requirements, it's also a matter of whether your home, the business that you're running, that's something that would be something they would want to do. So. How many hours of training are needed for personal care home administrators? Okay, that's 24 hours per year. And if you still need credits, where can you go for them? I think what we could do is give you a call if you need more information, but we do have a training resource directory on our website, and we also have a couple of training announcements under our training section for the training we contract for with Temple University Institute on Protective Services and with Northampton Community College. They provide training free of charge for personal care home and assisted living administrators to that count towards your 24 hours. They have them all over the state. Many of those have already taken place this fall. There will be another schedule available for the spring, but there are still some dates in certain areas yet this month and early next month.
Yeah, some of them run up through the end of 2018, but my understanding is the spring 2019 schedules will be out soon.
Right. And there are a number of other training sources available on our training resource directory. And also, if you need online training, you can have 12 of the 24 hours can be online. If you just need a few more hours of online training, all of the training through the HICUs, which are the Healthcare Quality Unit, which you can Google and find real easy, but if not, let us know and we'll direct you to them. There's training on those websites as well that count for personal care home administrators and assisted living administrators. Sorry. I'm sorry. You wanted to answer that question? Okay.
So we also got a question here that regarding ancillary staff persons or potentially ancillary staff persons, like someone who might run a bingo game, and what kind of training they need within the first day and thereafter. So to try to keep this simple, for somebody who does something like an activity and that's the only thing that they do, that they might not need any training in that case. They aren't providing any direct care services to the residents. They don't have unsupervised access. It all depends on what kinds of duties the staff person does individually. So it's not really a case-by-case situation, but it's something where you might have somebody that has various other duties that you might want to discuss with us, and I'd recommend that you give a call and speak with me or your regional director in the region. But someone like that, I'm not even sure that they would be considered an ancillary staff person. I mean, it says volunteers or term could potentially include, or it does not include visitors or individuals who provide non-direct services or who provide entertainment on an occasional basis. And that's
right.
what I would include.
If that's merely an entertainment type of thing.
Yeah. I mean, if that's all that they're doing.
Training.
As long as they're not providing direct care. I feel like I just opened Pandora's box with that comment, but...
well, I believe there's a Q&A coming down the pike on that one.
Okay. So stay tuned. There's more information coming on how we measure that.
Okay, and another question, if a resident's family member provides direct care, does the family member need to be trained as a direct care provider?
I'm a visual person. I got to read the question. No. I mean, I can elaborate on that. I think I'm not quite sure why someone would think that they do.
Well, if they're providing direct care to other people other than their family member.
That could be a problem, but more from a liability standpoint for yourself than from a regulatory standpoint. You probably don't want family members providing direct care to other residents, but if they're coming in and doing and just doing some basic assistance for their loved one, I don't have a problem with that. I think the bigger concern you might have is if they have a problem with that, because we frequently get complaints from family members who say that they have to provide services that the home should be providing. So, but no, they don't. A family member wouldn't need any kind of direct care training or anything.
Like we got a few more questions.
One question has come up. How many hours does a personal care home administrator need per year? 24 for PCH.
And for assisted living, it's also 24. But if somebody works as both, somehow or in both capacities. Does anybody work in both capacities?
I think so.
Yeah, you only need the 24. You don't
Right.
have to have 48.
However, I don't want to overcomplicate that too, but keep in mind that if someone is working as a personal care administrator and a assisted living administrator, that there are different hourly requirements for each type of facility, and I feel like that might stretch somebody pretty thin.
It is 24 for both.
Yep.
Okay. Starting to doubt my memory.
In assisted living, a special care unit that cares for those with cognitive impairments, does it have to be secured? Or if you are caring for residents who have cognitive impairments in an unsecured unit, are the training requirements of 8 hours required even if it is not a secured unit? I believe the answer to that is yes, and the training hours would be the same in any case. But a special care unit is a locked unit. If it weren't a locked unit, it would just be an assisted living residence. Now, that isn't to say that some residents who may have mild cognitive needs or a traumatic brain injury or some other kind of need that could affect mental functioning, that isn't to say that they couldn't be served in an assisted living residence rather than a special care unit. But obviously, it would be a matter of, do you have the staff and the expertise and the policies in place that would meet that resident's needs.
And again, I think we spoke to this earlier on, that when you do have people on your unit who do have cognitive impairments, that can change and can change pretty radically within a short period of time. You might think that you can offer those folks strictly a non-secure unit. However, a person may not be an elopement risk, for example, when they come in or shortly after the diagnosis, but they might become an elopement risk as their disease process progresses along. So having a secure dementia unit would be beneficial if that's
Special care unit.
Special care, yeah.
Yeah. If a resident receives services from a hospice aide, does the hospice aide need to be trained as a direct care staff? No. The home is not required to provide direct care staffing to somebody who provides a supplemental health care service, which is a whole other conversation as well. But
so is that the case even when the home hires them?
no, that's the exception. If the hospice aide works for a supplemental health care service provided by the home, then they're a staff person in the home and they require the direct care training. But if it's someone coming in from an outside agency, then it's not the home's responsibility to provide that. Presumably, they've received that from the hospice agency which they work for, who is licensed by the Department of Health. So those protections are also in place there.
All right. Well, I think so here comes more questions. Thank you. Okay. This is a fragmented question. It says, so would they need fire safety? But I don't know what that's referring to. I think this same person already has asked a question. I'm going to see if I can find it.
Maybe they're talking about that hospice aide.
I think they're talking about personal care home administrators. Everyone in the home, all the staff in the home.
Personal care administrators?
Yeah.
Yeah.
A little off topic, but yeah, I mean, because the administrator in an assisted living and in a personal care home, they
all staff of any by any definition of the word needs to have a variation of fire safety training. And in fact, I would go a step further and recommend that anyone who comes into the home regularly at least be provided a basic orientation on your emergency procedures and fire safety mechanisms. I mean, even family members. It's not a bad idea for family members to be acquainted. I mean, obviously you have the signs up and everything, but to be acquainted with the various exits and be given at least a basic explanation of what happens in the event of a fire drill.
Because many family members are there with their loved one over meals. They may eat with them. You know, they're spending periods of time, hours with them.
Yep.
Right, and that's not something required by the regulations, but it's certainly a best practice.
Right.
Okay. You want to take that one?
What if I started as a personal care home administrator in the fourth quarter of the year? Is the 24 hours prorated?
And this would apply to assisted living administrators.
I mean, if you've received, yeah, it would apply to assisted living administrators as well. If you received some number of hours of training within that year, regardless of what home you're working at, that would obviously all count, provided that you have documentation of it, or can provide some kind of documentation of it. If you're starting at a new home and there's been no training prior to that, then you could start with the new training year based on your hire date, or however the home does it. Again, these are some of these kinds of situations are ones that I look very closely at before determining if a violation exists, because you can understand if you start at a home and there's 2 weeks in the year left, you might want to make a slight tweak to your training year, at least for the first year.
It would also depend if you had just passed the 100-hour course within that year, because
True.
Then that would count your 24 hours for that year.
That's true. That would be more than enough to meet the requirement. So.
Okay, well, I'm thinking this concludes our questions. I don't see any more coming. We made it an hour and 15 minutes, about. Hopefully, we covered everything you need us to cover. I think Cody has a lot of knowledge and was able to share that with us, so it was very helpful.
If you say so.
Oh, no, here's some more questions. Thank you.
We'll do a couple more, and if we miss any on the webinar right now, then we'll certainly get an answer to you if we have contact information, or if you can give us a call after the webinar is complete, we can get back to you. If assisted living and personal care are provided in the same building, can direct care workers work in both? For example, 16 assisted living rooms and 36 PCH rooms. Yes, provided that those staff meet all the requirements of both chapters. And there's quite a bit of overlap, so that shouldn't be too difficult. But obviously, you're still going to want to make sure that your staffing hours are compliant in both settings.
Right, they wouldn't be able to cover both at the same time. They'd have to be counted in one or the other.
Right, because one of the requirements is that the assisted living be a distinct part of the building. So you want to make sure that your staffing levels are still up, but I see nothing that would prevent you from using a direct care worker in both types of settings, provided that they meet the training and eligibility requirements of both chapters. Do hospice, home health aides, and staff need to complete the ancillary orientation and yearly training? Not quite sure. Let me look here real quick what the ancillary orientation is. No, I think you're talking about 65F, which is the ancillary staff persons shall have a general orientation to their specific job functions as it relates to their position prior to working in that capacity. And hospice, home health aides, they're not ancillary staff. And direct care staff aren't ancillary staff. So that doesn't apply to them. Again, hospice home health aides, there's no training the home is required to provide to them beyond the criminal background check. Presumably they're receiving that training from the agency that they work for, or various other trainings. You mentioned a beautician or barber fall under the direct care staff. Wouldn't this fall under their licensure? And that's the tricky part about that. We might need to ask for more clarification, but here's the way I've always handled it. If somebody's coming in, say a volunteer comes in to cut hair once a month, even though I would consider hair cutting to be a part of personal hygiene and a direct care service, if that's the only thing that someone's doing on a volunteer basis, I would not consider them a direct care staff person. Again, there are other trainings like the fire safety that I would expect you would have for them simply as a matter of safety in the home, but something like that doesn't rise to the level of a direct care staff person. We can certainly ask for more clarification to make sure that I'm right about that, but that's been my impression for many years. I think that's the last one on the sheet.
All right. Well, then we're going to end the webinar here. I really appreciate all of you joining us. Like I said earlier, if you have any questions, give the hotline a call or email the address on your screen.
Can I give my email as well?
Or you can email Neil Cody, the assisted living.
I'll give my phone number as well, but honestly, you're more likely to get a quick response by email from me. So my phone number is 717-772-4674, 772-4674, and my email is ncody, N-C-O-D-Y, @pa.gov. And I'm happy to kick around any of these topics if you want to have a philosophical discussion about staff training.
All right. Okay, well then we're going to conclude the webinar here. Thank you very much for joining us. And if you have any other ideas for topics, please let us know. Thank you.